I'm Allan House. I'm Emeritus Professor of Liaison Psychiatry in the Medical School in the University of Leeds. Liaison Psychiatry involves the overlap between physical and mental health and healthcare. And in the setting of our discussion today, that means particularly people living with severe, long-standing, sometimes life-limiting physical illness, and people who come to the hospital with self-harm or with suicidal thinking. In assisted dying, as we're discussing it now, what happens is that a doctor, a qualified doctor, issues a prescription of typically several drugs together of a type and an amount that if the patient takes them as prescribed, it will end their life. So that sounds like what is called in some places physician-assisted suicide. It's the doctor providing the means for suicide. The people who argue that it isn't say, no, that these patients are going to die anyway and all they're doing is choosing the time and manner of their death. But of course that's what all suicides do. They're choosing the time and manner of their death, and the circumstances that lead them to make that choice aren't relevant to the definition. So, to my mind, medical assistance in dying is physician-assisted suicide. As a psychiatrist, I'm opposed to legislation that will enable medical assistance in dying for two main reasons. First, because it exposes the most vulnerable and marginalised people in society to risks, and no amount of safeguarding can entirely remove those risks. It's a human system, and human systems always include failure and error. And the second reason is that it fundamentally changes our approach to suicide in society at large. Campaigners will often claim that carefully drafted legislation will ensure that medically assisted dying is only offered to the right people and that vulnerable people of various sorts will be carefully looked out for and treated differently. We know that there's no human system that works without fail. It doesn't matter if we're talking about manned space flight or running a nuclear power station or high-risk healthcare interventions in ill children, where the stakes are extremely high. We know that errors happen. So somebody who's prepared to say that a system can work without fail is either intentionally or unintentionally not looking at where the sources of failure or error might be. When the concern is raised that assisted dying legislation represents a threat to the marginal and vulnerable people, the line of response goes something like, oh, we wouldn't, we'd keep our legislation very tightly controlled. We wouldn't go in the direction of Belgium or the Netherlands. We're not going to be euthanizing children. We're not going to be offering this to people who don't have physical illness. We're not going to be getting the sorts of levels of numbers that they get in Canada. It's difficult to know if that's going to be true. We have to take it on trust, whether it's going to stay there or if this is a foot in the door. Every country that has modified its original assisted dying legislation has modified it in the direction of making it more liberal, increasing access to different groups of people. There's another risk, though, which is the wider risk to society when you legislate the idea that certain suicides are to be supported, that there are lives not worth living, and that we agree with that and will help people end those lives. That's a more intangible risk, but it feels to me like the greater risk long term. As things stand, it's illegal to assist suicide. So assisting suicide, legislating for that to be illegal, must change the law, and that will then change societal attitudes. As things stand, and we have a national suicide prevention strategy that takes the stance that all suicides should be things we work to prevent. And if we're now saying, well, no, there are some suicides we work to prevent and some suicides we actually support and assist, then that's going to change attitudes in quite profound ways. And it seems to me reduce the drive to prevent suicide. Instead of thinking what we should do is assist people whose lives have become intolerable to end their lives, what we should be doing is working to stop it being the case that somebody with a severe physical illness finds their life intolerable. Throughout my career, I've seen people who are living with severe physical illnesses of all sorts. Cancer often gets the front of stage, but heart disease, kidney disease, neurological conditions all have big impacts on people's lives. About 1 in 5, about up to a quarter of people do experience depression at some time when they have a severe illness. It affects their quality of life. And a lot of people, perhaps 1 in 10 or more people, entertain what we might call very negative thoughts about life not being worth living, for example, life not being worthwhile in the state that they're in. A lot of people who entertain thoughts that they want to end their lives change their minds, either over time or because things don't develop in the way that they thought they were going to, or they find a new treatment, or they just readjust their values and thoughts about things. The psychiatrist's job is to try and help people do that, stepping back and thinking. We know from other countries that have passed this legislation why people ask for assistance in dying. And although campaigners emphasise concerns about symptoms like pain or incontinence, far, far and away the commonest reason people ask for assistance in dying is because they're worried about loss of independence or what's called loss of autonomy. I think the distinction is the loss of independence refers to physical independence, so that they need help with various ordinary day-to-day functions. And loss of autonomy means something to do with loss of ability to make your own decisions about what happens in your life. And we know from suicide statistics more generally that people at most risk very often have no social support in their lives, or they're living on their own. They're socially isolated or feel lonely. So these more social risks, if you like, or vulnerabilities, tend to get neglected when we talk entirely about mental capacity or the individual right to choose, and imply that the only thing we need to know is whether somebody's got mental capacity and hasn't got a severe mental illness. Whereas what we really need to know is more about the social context that drives them to the sorts of thinking that they have about their lives. We know that social and financial inequalities do affect access to health care. There are some very long-standing observations about that, right, including primary care. Poorer people have less access to a GP. A GP serving poor areas has bigger lists and sees people less often than GPs in affluent areas. And that goes all the way through into secondary care, that social inequality is matched by health inequality. And if we think of medical assistance in dying, if you like to call it that, that's a form of healthcare. So that how people access it and why is likely to be influenced by these social factors and not just by disease factors. One of the important things we need to do is to think more imaginatively about how we offer help for the mental health impacts of living with severe physical illness. And by that I mean there's more to it than simply screening people for severe mental illness and treating that. We have to understand how social context influences people's approach, thoughts about their own life, thoughts about living with disability and illness. and we have to join up our services so that we go from first diagnosis through to hospital care, perhaps for the initial treatment of things, to longer term follow-up for people who are living with what might be a life-limiting illness. No doubt services are better than they were decades ago, say at the start of the foundation of the NHS, but we still have a long way to go in delivering high quality services to everybody who's living with disability, with severe physical illness, and moving towards the end of life. The best services are models of what every service should be, but every service isn't there yet. Suicide prevention, more generally, involves thinking not just medically about people who are at risk, but socially as well. Some of the risks reside in inequalities, lack of access to services, social isolation, a sense of disempowerment, so that it's part of a wider social and political policy to do something about suicide.